I'm on my Shakti mat tonight, I should say, and I thought I'd share some thoughts while I do this therapy. Ooh, it's been a while. I want to talk about how I wonder sometimes whether my patients would still make the same choice, knowing what they know after the fact. Let's talk about it. Okay, so I think I'm gonna put the microphone on my chest, or actually I'll put the microphone here. Hopefully you all can hear me okay, and I'll try my best to keep eye contact as best as I can. It's really distracting. If you don't know what a Shakti mat is, it's a mat with a bunch of needle-like points. In my case, it's plastic, but it feels very sharp, and there's different levels to it, and the higher level you go, the more pressure points are on the mat. So when you lie down, it feels like a bunch of little sharp tacks going into the back of your skin, into the skin of your back. It gets relaxing after about 5 minutes, but for the first 5 minutes, it's really, really painful. In any case, try to focus here. If you're watching this video, it means that I've successfully recorded a take that I'm satisfied with. This has turned out to be an incredibly difficult video to produce, mostly because I think I started by attacking the wrong direction with the idea. Initially, I wanted to make a video about what considerations people may want to have when filling out advanced directives for themselves. But no matter how hard I tried, I always ended up stalling. And that never was an issue with my previous videos. And I realized that that was a sign that going the route of just talking about advanced directives and making a practical video, it's not my style. I like telling stories. So that's what I'm going to do. So if you're watching this, it means that this was successful. And let me know if you want to see more videos of me doing the Shakti mat. May not look like it, but I am in severe pain right now. So I like to start by telling two sides of a similar story. Let's suppose there's patient A and there's patient B. And patient A and B are both on a ventilator, dying, in the ICU, multi-organ failure. So naturally, neither patient A or patient B are able to make decisions for themselves because they're very sick, very critically ill, and they've got tubes going in and out of their mouth, and they're on a ventilator, so they can't talk. They're sedated, they're in medically induced comas. Now, imagine there's family for both patient A and patient B. When approached by the critical care team of the hospital, patient A's family says, I understand how sick my family is, but I want you to do everything that you can to keep them alive. Patient B's family says, We understand how sick our loved one is. This is something that they never wanted for themselves. We would like you to take them off of life support and allow a natural death. Patient A continues on for a few more days and unfortunately dies from severe illness that, despite the medical team's best efforts, they could not reverse. Patient B, that same day, was liberated from the ventilator and started on medications that kept them comfortable so that they wouldn't feel like they were having trouble breathing or drowning or choking or having pain or anxiety. And they passed away in their sleep off of artificial life support. And what I often wonder is, would patient A's family do that again, knowing what patient A went through? Suffering on artificial life support, fighting for their life, yes, but it was an uphill battle that they were destined to lose, unfortunately, and the medical team knew this. Because they told the families, both families, that the patients are unfortunately going to die no matter what they did. And then there's patient B's family. I wonder if transitioning off of artificial life support and liberating them from those machines and allowing a natural death, allowing patient B to not suffer as long as they would have, not linger as long as they would have, and have some dignity being protected at the end of life instead of tubes going out and in every which direction. I wonder if patient B's family would do it again too. Now, I want to tell some real stories. Patient A's family reminds me of this one patient that I had whose family are deeply religious and put a lot of faith in God. And on top of that, patient A's family, some of the family members have also witnessed what happened to their family member as they passed away. The family member had been what we call do not resuscitate, or they had a DNR, and patient A's family felt like, well, I should say like patient A family, they felt like because of the existence of a DNR, not enough was done at the end of life to try to keep the person alive. And they felt like there were stones left unturned. And also they felt like the medical establishment just let their family die and did nothing as their family member died. And that informed their decision to make the decision, like in patient A's case, to do literally every single thing possible that you can think of. Transfuse the blood, do the dialysis, give the medications to keep the blood pressure up, doesn't matter how many it takes, do the intubation, do the procedures. And in the end, we ended up putting patient A, or someone like patient A, through so much I'd imagine pain and suffering with the same result, unfortunately, that the medical team has already foreseen prior to doing all of that. And then there's patient B's family and people like patient B, where the story is usually the opposite. Now, sometimes they were religious too, but often my experience is that they're much more logical and they tend not to be religious. A lot of them are atheists or agnostic. Again, some of them are religious, but people similar to patient B's family sometimes have also experienced what patient A's family experienced in the past. So maybe they had a mother, a grandmother, grandparent who they saw what it meant to do everything possible, and they saw the person being whittled away until there was literally nothing left resembling that person when they were still alive. And that experience was drawn out over the course of several weeks, sometimes even months. And towards the end, everyone was exhausted, everyone was sad, everyone was broken up, and then the person ended up still dying despite their best efforts. And so they made a promise to themselves that they would never do that again to anybody that they loved, and they would never want that for themselves. In my experience, I think people like patient B's family are less likely to regret the choices that they made, because they understand that the grand scheme of things is the person will die, and they trust us enough and they place their faith in us to make sure that if that is the case, we provide as much dignity and as much comfort while we still can provide dignity and comfort towards the end of life. And studies do show this. Studies show that people who choose to pursue the route of patient A's family, they tend to live with more regret. Sometimes they find that it wasn't worth it to turn over all the stones. It wasn't worth all those sleepless nights and watching their loved ones suffer and be whittled away into nothing like they were when they were still full of life. So that's what I wonder about sometimes. And how does that tie into advanced directives? I think the problem with advanced directives is it's often vague. People may have healthcare proxies, but they don't talk to their healthcare proxies about what to actually do when they're really sick. And more often than not, when I ask someone, so what does your healthcare proxy know about your wishes? People tell me, oh, we haven't talked about any of it. Or they have a living will, which is a document that's drafted up by a lawyer's office that is usually pretty generic, has generic wording that says if I am about to die or I have some sort of terminal illness, that I do not want to be resuscitated and I do not want to be intubated and I want maximum medications to maintain and achieve my comfort. The problem with these the advanced directives and living will is that they're not really detailed enough And the wording is usually so vague that it's hard to apply in reality. So it's not uncommon that someone produces a living will to us and says, well, this is their wish, and this right here says they are DNR. But in reality, it's like, well, they're DNR under these circumstances, and are they currently in one of these circumstances? And it's hard to say sometimes. It's a gray area most of the time. So the moral of the story for patient A and patient B is, I want people to give some thought to whether they would want, for themselves or for their loved ones, talk to their loved ones who may be struggling with chronic illness and get ahead of this conversation, whether it is right for them to even end up in that situation in the first place. And there are things that everyday people can do to prevent themselves from ending up in the ICU, on ventilators, on artificial life support, and dying from major organ failure every which way. And that is to fill out documents with your doctor or your lawyer and consider placing an order for a do not resuscitate and do not intubate if it is right for you. Arguably, these two decisions are some of the most important decisions you can make for yourself in advance in healthcare. That it's not set in stone, so it can be changed or revoked or altered at any point in the future as you see fit, but who is this right for? It may not be right for the 20 to 30-year-old, maybe even 40-year-old with no medical problems, no serious health issues, and they're young. And they end up in an accident, or they just have some sort of congenital heart disease, something that you were born with but you never know, that causes their heart to stop, for example. And in those cases, it might actually be a good idea to do CPR, to put them on ventilators, to give them a chance at recovery. When might this ICU scenario and life support not be a good idea? While there's no 100% rule that catches everything and rules everything out, there is a general rule of thumb that if you have a major chronic illness or multiple major chronic illnesses that cannot be cured, that you are living with, it may not be in your best interest to accept these aggressive resuscitation measures, such as CPR and being intubated and being put on mechanical ventilation. And the reason is because most likely when you have these chronic illnesses, you're at a point where we're pretty sure your heart is not going to just stop by itself, with the exception of serious end-stage heart disease. But that's a different conversation. We're pretty sure that you don't have a congenital heart disease that's going to stop your heart and stop your breathing just randomly at that point. When people with chronic illnesses that can't be cured end up in that situation, it's usually because one or more of those illnesses have progressed to the point of basically no return. So even if you were to be put on artificial life support, even if your heart stops and we restart it during those times, you are still likely living with end-stage disease that really nobody can cure or reverse. And so when we put people like that on life support in the ICU, many times what we are doing is actually prolonging people's dying process and delaying them from finding peace and relief from suffering, rather than meaningfully prolonging their life and bringing them back in a state that they'd be happy living in. And this goes with a lot of different illnesses. Heart disease, which I mentioned earlier, if you have end stage severe heart disease, the chances of you being brought back with CPR, shock to the heart, and having a good quality of life afterwards, it's pretty slim. It's really, really slim, usually, especially if this happens outside of the hospital. And things like liver disease, chronic lung disease, COPD is another major one. End stage kidney disease, if you're on dialysis, you should know that something like this may happen to you with dialysis. It's really hard on the body, on the heart and the brain. People have brain bleeds, people have cardiac arrests, heart attacks during dialysis. Basically, any major organ dysfunction, one or more, increases your risk of your heart stopping and you stop breathing. And it also increases the risk that when you get these procedures done, in the case of a cardiac arrest or you stop breathing, it increases the risk that you are not going to be brought back in a state that you desire to be in. So there's a common misconception that, well, if I'm going to die anyway, might as well try, right? And while that's fair, yes, absolutely. If we don't do CPR, if we don't put people on ventilators when their heart stops beating, when they stop breathing on their own, they will die. Absolutely true. But the misconception that it's better to do something than to do nothing at all may not be quite right for some people. There's this huge gray area where you're physically alive, but you can never leave the hospital again. You may be in a vegetative state, a vegetable, quote unquote, or you may suffer such severe brain damage that you're in between, like you have no control over half of your body, like you had a major stroke. And these things are not really commonly talked about when we do advanced medical planning for people. And it's funny because a lot of times I hear people ask, I hear doctors and I hear nurses, they ask people whether they would want to be resuscitated. And it typically goes like this: if your heart or your lungs stop, do you want to be brought back? Do you want CPR? Do you want us to put you on a breathing machine? And that's it. There's the promise of continued life if it works, but there's no mention of any of the downsides that you could survive with if you were to survive. So let's talk some rough numbers. When someone's heart stops, I think that's the absolutely worst thing that could happen. When someone's heart stops, outside the hospital, there's usually about 10% chance that they can be brought back to life and eventually survive, brought to the hospital, eventually survive to leave the hospital. 10% chance. When this happens inside the hospital, but outside of the operating room and outside of a cardiologist catheter lab table, these odds increase a little bit to about 20% who survive to hospital discharge. And when someone is on the cardiologist table or a surgeon's operating table, these odds improve even further to about 30 to 40% from various data. Now, that's just surviving to hospital discharge. But what kind of a state are you in? The data really shows that when people survive, there is more than a 50% chance that you will end up with, depending on which source you read, but 40 to 60% chance on average that you will end up with some sort of significant neurologic impairment, meaning either you had a stroke, which you now cannot control one or more multiple parts of your body, or you are in a complete vegetative state. You're not brain dead, but you can't wake up, you can't breathe on your own, you can't talk, you can't eat, you can't touch your family. And that's what people should know. So that's the heart. When we talk about the lungs, things are a little more optimistic and a little more varied. And so a lot of times I tell people it's really up to you whether you want to try the ventilator or not. Some conditions that I wouldn't necessarily recommend agreeing to a ventilator, again, if you have end stage organ failure and there's nothing anyone can do about it, chances are the reason you ending up on the ventilator is because of something related to the organ failure or one of its complications. And if that happens, the chances of you getting off the ventilator is really, really slim. Same thing with most commonly COPD. I think that's one of the most notorious conditions where people generally are not expected to get off of the ventilator, especially if you have to be ventilated multiple times and you fail extubation multiple times. What might be reasonable is if you don't have any medical conditions at all, or maybe something that's quite easily fixable, curable, like you're undergoing surgery to remove your appendix. That's fine. Most people survive that, and under those circumstances it's controlled. So you have to consider whether you're okay with controlled surgical reasons for being put on a ventilator or in an emergency situation when you're being put on a ventilator. Usually the rule of thumb is that for emergencies, the odds of coming off are usually lower. Whereas controlled cherry-pick conditions where you are optimized and in good health relatively for surgery or a cardiac catheterization, things like that, that may end up with you intubated, those are generally much more favorable than emergencies. But when we talk about the heart, again, it's not really as optimistic for the most part. So I think I successfully talked about what I want to talk about when it comes to advanced care planning. There are other things like IV fluids, whether you want antibiotics, whether you want dialysis for kidneys, whether you want blood transfusion, whether you want a feeding tube. In my opinion, none of these are generally emergencies where it can't be discussed at the time of needing them. But the heart and the lungs generally are emergencies that when you need them, you're most likely not going to be awake enough to agree to them or disagree to them. And oftentimes, your family will also not be immediately reachable. So they as medical personnel will do these things to you and then talk to your family later. So then in those situations, we come across a dilemma where now we've started something that if we were to take it away, it feels like we're actively killing somebody. And that's how a lot of people feel when they quote unquote pull the plug. That phrase is so commonly used, pull the plug, that it's a euphemism, but it does carry a great sense of guilt for a lot of people. And that's also something you should take into consideration when you make decisions like this ahead of time for yourself. Is who's going to make decisions for you, and are they okay with making the same decisions you would have? Because if someone has great difficulty, especially if you've never discussed with this person, your healthcare proxy, your trusted healthcare proxy, if you've never discussed this decision with that person, they may find it very difficult to resolve this decision within themselves and their conscience. And while battling their conscience, you may end up suffering for a long time on artificial life support until they finally decide one way or another. And it usually is, well, we'll continue to do everything until I figure out what it is that this person would want. What you also need to know is in most, if not all states, legally, emergency personnel such as police, firefighters, EMS, ambulance, they are required to provide these life-saving measures unless stated otherwise on a legally recognized medical order. And this legally recognized medical order comes in various different forms. I encourage you, if you're interested, go speak with your doctor. They know what to do if you want to fill one out. I practice in New York State, and we call it the medical order for life-sustaining treatments. Sometimes it's called a physician's order. Sometimes it's called a portable order. Whatever. Every state usually has something similar. And you can go to your doctor's office to discuss and fill one out if you want to ensure that whether you want it or not, you get it or not. And this order is something that medical emergency first responders have to recognize legally and respect legally. So it would be incredibly important that if you have something like that, to keep it in a place where it's easily accessible and visible, so that if an emergency happens to you, they know what to follow. Make copies, give it to people that you trust and need to know, including all of your doctors. And fun fact, people have asked in the past and debated whether if you tattoo a "do not resuscitate" tattoo on your chest, whether emergency personnel and doctors will follow that. And the verdict is unfortunately not, because usually, a couple problems with that. Usually you need witnesses to this form, and secondarily, it's not signed by a doctor, so nobody actually knows whether it's a legitimate medical order or not. So just in case you're thinking, oh, I'm going to tattoo something on myself, I wouldn't do it. Just talk to your doctor and figure it out with them. So it's been about, I think, 30 minutes now, if my timing's not off. And I think I'm just about done with this Shakti mat. Bit of a long episode. Thank you for sticking with me. And again, please let me know. Do you like this format, or do you prefer if I'm walking around outside? Yeah. Leave comments. I'll definitely get to them. I really appreciate any ideas. If you want me to talk about anything, pick my brain from a palliative care doctor's perspective. Again, all of this is just educational and public service announcement. It's not meant to be any personalized medical advice for anybody. And if you're ever in doubt, speak with your doctor. Don't ever trust anybody, or if you do trust, verify. Thanks for lying down with me today. See you on the next one. Peace.